in a marathon. And so let's get this up to here for you. And let's talk about, here's a question. This is a question for IBM Watson. This is a pretty tough question. What does a marathon runner, this is not a joke, what does a marathon runner and a patient with hip surgery have in common? So if this was a CME program at the end, you'd have to answer this question. So here's a patient we're going to talk about today. One of the patients, we're going to talk about several. This is a gentleman who came over here 2 days ago. He's a 48-year-old Caucasian male, married Army Ranger Colonel, who is would be called a very long distance runner, very long distance, who in December 2016 developed sharp pain in the back while running. Went up his neck into his head, wrapped around the chest. First came on when he was running. He thought it was a back injury. He got adjusted by a chiropractor down the street from him. It improved. He was happy with that. He ran the half marathon in January for Gasparilla. The discomfort recurred during exertion, felt like a hot poker. Not sure what a hot poker feels like. Don't want to know what a hot poker feels like. The longest duration he's had this discomfort was 3 hours. He went for aggressive physical therapy. He got acupuncture. Pain significantly decreased. Was training for the next half marathon in Orlando, but he gave it up. He said, I just can't do this. This is just too much for me. So he went to a back specialist, received laser treatment to his disc in March. Now he's waking up with the pain in the early morning. It's not that the pain wakes him up. He wakes up and has the pain when he wakes up. He's scheduled for a back MRI April 25th, coming up, about a week. He was sent to cardiology to rule out cardiac issues. So you go there and see if they know anything about you. So normal EKG, normal everything, except he has high cholesterol. He's on Lipitor. He was seen 2 days ago. He came to my clinic. Smoked cigarettes as an amateur for about 5 years and then quit. No family history from his father. He's in a motor vehicle accident and died young. Mother has hypertension, elevated cholesterol. His physical exam is normal. So that's about it. He explains this pain very graphically, very significantly, and it's interfering with his life, and he can't get it to go away. It seems to be getting worse, coming on with less. Here's his EKG if you'd like to take a look at this. The first thing you notice is a profound sinus bradycardia in the 40s. Hey, the first thing I think of when I see somebody with some kind of pain who has a profound sinus bradycardia is, wow, this is a good one for a CTA. And so, hey, I don't have to slow down the heart rate. Got just what I need right here for a CTA. And maybe he's, you know how vagal people are and how parasympathetic they get when they're runners. And so runners are great for coronary CTA, perfect heart rate. It's got a little maybe first degree AV block there. At least it's close. And then QTC is normal. Everything else looks pretty good. So the only thing interesting about his EKG, and there's nothing there. And he is a runner. Parasympathetic tone increased. Okay, what are we going to do? We got some test choices. Are we going to do a stress spec scan? Well, you know I'm not going to do that. Maybe you're going to do it. But I haven't done one of those for like 10 years. So that's not going to happen. Are we going to do a stress echo? Well, there is a place for a stress echo. And so I do that sometimes, not as a primary screening test for a chest pain or back pain or neck pain or whatever it is. But I do them. How about a Lexiscan MRI? Well, that's superior. That's probably the top perfusion study now, that and PET scanning. So it's very, very reliable in the right hands, but you can't get them. Nobody does them. Nobody knows how to do a cardiac MRI. Well, it seems pretty simple. You just got to go out and buy a coil. Well, the limiting factor is $200,000 for software and hardware, and so that's a barrier to entry in a community hospital. So 150 university hospitals have cardiac CT, MRI. Have Lexiscan MRI, and the rest of them don't. And so we just happen to be a hospital that my team targeted that we were going to do advanced cardiac imaging, and that's how we happen to have it. Cardiac cath, well, that's easy, just go through the wrist, do a cardiac cath. I remember when Grunzig had one, and we were having a cocktail party, and he came in and said, hey, I had a cardiac cath 2 hours ago. I have normal coronaries. So I said, that's great, Andreas. He said, what made you do that? And he said, well, I just thought I'd show how easy it is, get somebody to do it on me. And piece of cake, radio. I said, oh, great, nobody's doing radio. Well, I just had someone do it for me on radio because that's what I wanted. So Andreas Grunzig, inventor of angioplasty. Calcium score only. Well, we could do that. 48-year-old. We're concerned about missing non-calcified plaque. Well, that happens. What, 6%? So not a very big deal, but it's usually young people, and so we sure don't want to miss that. So calcium score is not going to help much if there's nothing there. And so how about this? We do a coronary CTA stat. Well, why stat? I mean, this guy's been batting around since December with recurrent episodes of back pain. Why are we going to do this stat? Well, because I intuitively feel we need to do it stat. Don't have any reason other than intuition. So we do prospective, low radiation, 48-year-old guy. We do iDose. iDose, prospective step and shoot, and iDose is iterative reconstruction so that we go back and take a noisy image with low KV, and then we go back and get rid of the noise with a computer program with $250,000 worth of software and hardware. And so that's for one reason only, to get the radiation down to about 3.5 millisieverts or less. The other thing I like about it is, wow, his heart rate's in the 40s. So I don't have to give him any medications to slow him down. That's always tough when you pluck somebody out and you're going to do a coronary CTA and they got a heart rate of 85. And so we don't have to worry about that. Well, we do have problems. What are our problems? Our main problem is administrative. And that is we've got to get permission. We've got to say, Mother, may I to somebody. So who are we going to ask? Well, we got to ask TRICARE Prime. Well, why do I got to ask them? I'm a cardiologist. I'm taking care of this patient. What do they want? Well, they want documentation. What kind of stuff? Well, they want evidence. I don't have any evidence, Basically, I'm going on intuition. So there is no evidence. EKG is normal. What will they tell you? They say, well, he has to have a stress test first. Why do you want to do that? That's crazy. Stress test, any of those stress tests have a 40% false positive, 65% false negative. But the system is kind of bent. And so we've got to call over there to Humana and get TRICARE Prime to approve it. So I talk to my office staff and I say, hey, get him on the phone, get permission. He's going to sit here. He's going to get this study today. So then a little later on, I'm walking out the parking lot to go to the hospital to a meeting, and there he is in the parking lot getting in his car to go somewhere. I said, wait a minute, where are you going? He said, I'm going to have the test tomorrow. We're waiting to get permission. Nobody's given us permission, so I'm taking off. I said, no, you're not. You're not going anywhere. And I put my arm around him, and we take him back into the office and back to my folks, my team. And I said, look, he's got to have this test today. I don't care if I have to pay for it myself. He's got to get it today. That's what my instincts tell me. And so if I have to call the base commander, not the hospital commander, the base commander, if I have to call the base commander, we're doing this today. So, okay, he's back in the loop, okay, and we're waiting to get the test stat. Of course, I can send him to the ER. That'll cost about $20,000, but we'll get it stat. Humana has to pay the $20,000. They probably got it negotiated down to maybe $5,000 or less. So no big deal. So that's how you work around the system, like radar, and MASH. So patient instructed to get the test and come back with a DVD. He's got to go over there, get that test, come back over here, and sit in my office with the DVD, and we'll load it and look at it. So that is our plan. How are we going to read the CT? What if there's plaque? What are we going to tell about the plaque? Well, you have a common approach, organized, to reading a chest x-ray. Everyone does. You're not going to be able to read a study without having some kind of organization. And so EKG, you're going to look at the P waves, PR interval, QRS duration. You're going to look at the morphology. You have a way of going through that test, stripping it down to its essentials, and making a diagnosis. So regardless, you're not going to overlook anything because you got a systematic way of doing that. So how about a plaque? Like Sherlock Holmes over here, How about a systematic way of reading a plaque? We're going to talk about that. What's important about reading a plaque? What do I want to know? What do you want to know? We're going to tell you how to do that. We're interested in 3 big things, and then we're interested in 3 more things that leads to. So we're interested in form. What is the shape of the lesion that contains the plaque? What is the shape of the coronary lumen? What is the shape if it was reduced to a metal tube or a non-distensible glass tube? What would be the shape? Okay, so that's very important for computational fluid dynamics. And we're going to be using heart flow very soon, which is computational fluid dynamics with a supercomputer that's a tabular computer. Not only that, but we're using Watson, which is also a supercomputer, but not a tabular computer. It's an intelligent or cognitive computer that has algorithms to complete something called deep learning. It can learn on its own, unsupervised. There's supervised, like programming, and there's unsupervised. And it's got algorithms to go unsupervised. Sounds risky. We have to talk about that in the future. But we want to know about the form. We want to know about the composition. What do we need to know about that? Well, we've got fibrin material, we've got fatty, we've got fibrofatty, we've got calcium, got all kinds of stuff, many different Hounsfield units in the wall of the vessel that we need to understand what that composition is and what's aggregating. And what is the primary composition? What is it that makes it dangerous? What is in the form that makes it dangerous? And what about the function? That would be MPI. And we gave you that as a choice over here. CT MPI, myocardial perfusion imaging with a CT scan. And we're going to talk about that as we move on here. So, hey, risk. Once we know form, composition, and function, and form follows function. Remember that as a little slogan, form follows function. Once we know that, then we can tell you something about risk from having looked at these many times before. And so that's very important to have a database to be able to predict risk. And so with over 5,000 scans, now that we're doing about 5 a day, my fellow has 1,000 scans under his belt. The fellows before then used to get 300, and so we picked up a lot. So we should be able to say something from risk from all these patients coming through here that we see and we follow up on. And then a recommendation, what needs to be done to make him better or her. And then who does it? And where do they do it? And what are they going to use to do this with in terms of, best technique? And so these are important questions that you need to be asking yourself every time you look at a plaque, every time you look at coronary CT. So let's look at some coronary CT, and let's do a preview, and we can show some images. So we'll come back to these little images that I've plucked out, and we'll actually go to the study itself to show you the images, because we can do that very easily. And I've already been playing with this, as you can see, but I'm going to take you over here, and we're going to take you over here, and these are pre-digested. And someday you'll be looking at pre-digested images routinely, because you'll have an opportunity to see those because Watson will be pre-digesting them just like I do, and have this information available to you that it's already been totally sliced, diced, and analyzed by a supercomputer that's been programmed, hopefully, by me. And so here we go. We want to look at this volume rendered image. Everyone likes to see this because it's so real. And so we always show this to folks, to the patients themselves. We also can do little tricks like here it is doing the hurdles, you know, and we can have it doing push-ups as well. And so, but we like to look at this image, and we want to know about, in this particular case, the slices. And you can see this is probably a 64 slice scanner, because it takes 1, 2, 3, 4, and maybe 5 slices to put this heart together, and that's step and shoot. Each one of these was a step, and then another picture, and then a step, and then another picture. So we've got 5 slabs or slices, and you got to know that where these are, there can be a little ditzel in the coronary where it doesn't quite line up exactly like it's supposed to when these slices put together. So you need to be aware of that, and aware that you could have artifacts produced at this level, and you can basically put a cut through there, and it'll go through the vessel, and you'll be able to see, well, here it's not quite lining up right there in that plane. So that's that diagonal vessel, or ramus, no, diagonal. And you can see it's not quite lining up in that plane. So it is off a little bit. And so you keep that in mind, because you want to be able to read the artifact. So then we're going over here, and we're looking at circumflex. And I always look at the outside of the vessel, and I look and see if I can see some coronary calcification. I look and see if I can see some bulging, like that little deal there, and that's probably a little piece of calcium. And then I'm very much struck by this that I'm looking at here, and I say, wow, what is that? And so that's very, very interesting. And so immediately when you look at that, you understand that is a complex plaque, very complex. Look at that, all the components, the color. So we know immediately that this guy's back pain is related to that, because the chances of having both coincidentally, it's not going to happen. So this is causing exercise-induced back pain. And you can see here's the main left, circumflex, left anterior descending, first diagonal, second diagonal. We want to know the relationship to this first diagonal. There's a little piece of calcium right there in the first diagonal. So let's go inside and take a look at this vessel and see what we can find out about form, composition, and function. So we're going to go over here, and we're going to go right there, and we're going inside the vessel. And voila, here we are. Well, let's take coloration off so that we can see it better. And let me get this little thing out of the way here. And here we are. Well, very interesting looking plaque. You can see the column of dye narrows. You can see it gets real hazy in here. Let's move this around. And you see the column of dye is narrowed significantly. You see the wall of the vessel is actually spanning right across like this, and yet we've got this in the wall that in terms of Hounsfield units looks like contrast. Yeah, there's contrast in the wall there. So that would mean that's a little ulcer, an ulcerated plaque. And then there's this notch on the outside because there's an ulcer here. It looks like a notch, but it's not really a notch. It has that appearance, and I call it a notch because it's the label that I use in recognizing it, characteristics, because it looks like a notch. And so we call that notch pathology. And so look at this. This is interesting. We see this coming down, converging, you know, like perspective, where things converge on the horizon. these two lines are converging to here. And then that's like a funnel. It's called convergence. And so we got convergence, it's like a cone. And then we see, if we were going to use rocket technology, we would look at this and call this the throat of the nozzle. And that this whole thing is a nozzle, and it's a convergent, divergent, double cone. So this is one cone, this is another cone, this is the converging cone, this is the diverging cone, and this is the throat of the nozzle. So we got a convergent, divergent, double cone, and the throat here is a long throat. It's going from here to here. So that's a new characteristic of this particular plaque, is it has a very long throat. Okay, so we got a convergent. So when we talk about form, we've got a convergent, divergent, double cone. The convergence is long, the divergence is short, and the throat is long. And so all those things mean something hemodynamically. If you were using this for a rocket nozzle, this would tell you by the Navier-Stokes equations a lot of things about the thrust that was developing here. And then you'd have to measure these angles. And the perfect angle for perfect thrust is 18%. And so that would give you greater velocity. And so we're interested in velocity because we're interested in Bernoulli, and we're interested basically in the pressure-velocity relationship. And as the velocity increases, the wall pressure decreases, and so we have a low pressure zone inside there, but a high velocity. And then on the other side, it's low pressure, and the velocity slows down again. So we get vortices, eddies, and turbulence, all of those things putting pressure on the distal plaque shoulder, and lots of things happening with the proximal plaque shoulder. And so this is very complicated. Once you know the form now, and you know how the form is a significant factor. So now the other things we want to know about form is there's an ulcer in the middle, certainly on the proximal convergence area, there is an ulcer right there. There's probably a little ulcer down here too, in the length of the long segment of the throat has a little ulcer. And then the other thing you're going to find is that there's some calcium here. And you can see how brighter that is. And if we measure Hounsfield units, we can come up with, actually we can get into the 500s there by measuring that and finding the brightest spot. We can get in the 500s there and be able to tell you that that's calcification. So in terms of form and composition, let's talk about composition. So we can color code it for composition. And so we know we've got some calcium there, and calcium starts from the outside in. That's important for you to know that. It's linear and from the outside in. And this is not calcium. The bright yellow is calcium. The not so bright yellow is a combination of green and blue, which makes yellow, and it's sort of a flat, dim yellow that is just an artifact. And I can't help it, this software was actually written in 2 weeks. 2 guys were locked in a room, and they were supposed to write this software in 2 weeks back in 2003, and they slid pizzas under the door, and they gave them Cokes, and they just had to stay in there and write the software, and it hasn't been touched since. And so, because nobody interested in plaque anymore. It has to do with plaque burden, and the interest is in plaque burden, not specific plaques. And so for us to be discussing specific plaques is going against the grain of the group think in cardiology. And so we are interested in finding a lipid core that's a necrotic core that has a large lipid lake. And so there we go. We've got some of it is actually up this way. So let's get that on here because we want to see that. Here's some. Let's take a look at that. And there we go. So that's way upstream on this convergent divergent double cone. That's upstream a little ways. There is upstream there, and in sort of a right upstream here. There's this lipid lake that's significant enough lipid to be important, and actually has to be in this particular picture. 26% of this area is lipid in this particular picture of this wall, of this plaque, and the green is the lumen. And so we're interested in that being 26% of the area, and then 51% is fibrosis. And then the calcium, we can't tell you that because some of this is a blend and is an artifact in terms of the yellow being calcification. Just the bright yellow there is calcification. So we've broken this down into its components in terms of form and now in terms of composition. So the next thing is going to be function. So what is the function going on with this plaque? What's happening with blood flow? So how can we tell something about blood flow on these images without doing anything else? Because we didn't administer Lexiscan or regadenoson or adenosine or persantin or dobutamine. So we didn't try to maximize the flow of the coronaries so as to compare an area that can't be maximized because of a plaque that's obstructive, and to compare that to areas that can be maximized to give us the maximal effect of being able to see something. So we can't do that, but we did give this patient nitroglycerin, and nitroglycerin increases coronary blood flow and causes vasodilatation of the distal bed. And we are giving them iodine. That's what this is. That's color-coded green. And iodine is a vasodilator, and that's how people, when they get iodine, feel this flush, is they're vasodilating their arteries very quickly in their skin, and they feel a flush feeling that's like an ascending flush feeling as the iodine is distributed throughout the body and descending into the legs, ascending from the arm into the head and chest. And so let's go over and look and see how we can measure that blood flow. And so the best way for us to do it with what we have here now is to measure the amount of iodine that's in the myocardium. So let's go do that, measure the iodine in the myocardium. And so I'm going to do this. And we got to go over here, and we got to take off the patient info, and then we're back over here to measure the iodine. So I don't know if you've seen CT MPI, but this is a CT MPI. And it is hyperemic in that we've given the patient nitroglycerin with vasodilatation of contrast. So it's a double whammy, but not a triple whammy, no Lexiscan. And so we come over here and we see these dittles around the edge, which are considered artifact. So I can tell you we can dismiss that. And so what's obvious is this big area here of decreased iodine in the anterior wall. So that's fitting our pattern. It's going into the apex a little bit. We can see it in the anterior wall up here, which is color-coded by brown. And you see it anterior septal over here. And so it seems to be fitting the distribution of our coronary. So very nicely in that distribution. So let's go take a look and see why this is. And so we can go to coronary calcium scoring, and that's going to calcium score this patient, but we're not actually calcium scoring the patient. We're actually scoring the iodine, and we're looking for the iodine distribution within the left ventricular wall. And so we've got a poor man's measurement of iodine distribution. We really didn't need all that fancy software, because look, we can see there's a lot more iodine in the posterior basilar myocardium, inferior myocardium, than there is in the apex. And the apex could have some artifact because sometimes we get some beam hardening lines coming through the apex that darken it, just like we can get some in the posterior basilar area. But when we look in the anterior wall, there's decreased iodine compared to the inferior wall. And we can also do this without color coding it. And look at this, we got lots in the inferior wall and not much in the anterior wall. Let's go over here and take a look. We'll go back to our gallery and we'll look at this without color coding. And so let's take a look at that, no color coding. And we'll see how this is going to look. And there we go. And so a lot of iodine In the inferior wall, the apex sometimes can be artifact, the posterior basilar can be artifact, but look, the anterior wall compared to the inferior wall has a lot less contrast, a lot less iodine, and therefore this is the myocardium that's subtending the severe blockage, and it means the blockage has slowed down blood flow, and that's led to less iodine in the myocardial wall compared with, say, the right coronary or the circumflex. So now we've got a CT MPI with hyperemia caused by nitroglycerin and contrast, both vasodilators. So now we can go back to our original images, and we can go back to our analysis. And so we're going to look and see if there's been any myocardial damage. So that's our next step. So let's go over here and look for myocardial damage. Well, how would we detect myocardial damage? Well, we would detect that basically by getting rid of the coronaries and looking at the myocardium and look for myocardial thinning. Well, don't see any myocardial thinning. What else are we going to look for? Well, we're going to look for fatty replacement of the myocardium. Okay, that's the next stage. So it's just like what happens in the coronaries. You get some fatty deposition in the coronary artery wall, and then that leads to some scar tissue, and then that leads to calcification. It's the same progression. Anything that gets damaged has the same repair process and the same remodeling process that you get, in the myocardium as well as in the coronary wall. It's analogous. And so we're looking here, and so we see no thinning, we see no fatty replacement, we don't see any mini fatty replacement or infarctlets, and we see no evidence of calcification, no evidence of fibrosis. So that looks pretty good. So we're happy with there being no infarcts, because a gentleman talked about having his back pain sometimes for 3 hours. Well, we can see this plaque again while we're here. We can see the calcification while we're here. We can see calcium also at the origin of the first diagonal. So we need to study these things now, because we're moving into risk evaluation, which says there's a big hunk of myocardium involved, a big hunk of myocardium involved distal to this vessel. And so definitely we have a lot of myocardium. And so if we go back and look at the coronary arteries again, and if you want to measure the length of this coronary artery, which we can do that, and let me get up here, we measure the length, and put that up there, and we come over here, and we do that, and then we're going to come over here, and we've got this lesion and this length of coronary artery. I am told that if we measure this and go right down this, and when you get to 73, you've reached a landmark of quite a bit of myocardium involved, definitely over 10%. So we've got to 73 right there, and that's only halfway down. So if we go all the way down, we could actually resect that out. It's 97 millimeters long, distal to the lesion, and so there's a lot of myocardium subtended. And so we can actually do a fractional myocardial mass and calculate an FFR using the equations that Kim has, who's South Korean, or using the equations of a gentleman in Australia has. We could calculate what the FFR is on this coronary artery. You can also compare the myocardial perfusion images and calculate an FFR that way. So there's like 3 or 4 ways, and you can use heart flow and calculate an FFR. So you got like 4 ways of figuring out what the FFR is. And so we've gone through function, we've gone into myocardial mass, we've gone into a big bunch of myocardial mass that's involved in exposure in this particular patient to the risk of this plaque. So if we come down this way, and come around this way, and come around this way, we're going to get a big chunk of myocardial mass. And here we go. we're making some efforts to derive the myocardial mass that's involved with this artery. And so then we come around here, this is the right, and we're going to remove that. And so, and then we've got the circumflex already gone. We don't need the right coronary artery. We don't need the right ventricle, the right ventricular cavity. We're going to take that off. And we're reducing this to something that we could actually use computationally to derive myocardial mass. And there's a whole wall over here and the septum that's important with septal perforators. And then we've got anterior wall, we've got apex, lateral wall. Some of that lateral wall, especially over here, is going to be supplied by the circumflex, so we can take a bunch of this off. So here we go with the lateral wall. And then we're going to come down to basically the amount of myocardium that's supplied by this artery, and that's a lot of myocardium. And we can hollow this out. We could get rid of this contrast inside here very easily if we wanted to hollow that out. I'm not going to do that right now. Let's see. This will hollow it out. Yeah, here we go. Look, we hollowed it out now. And so now we can actually measure. We have a way of calculating what this mass is from this computer. And we can tell you what the mass is and pretty well calculate how much it weighs and what percent of the myocardium is involved. So we've arrived at this being a high-risk case and a high-risk patient. And so then we come with what are we going to do about it? And we're going to talk about that in just a minute. What are we going to do about it, about this high-risk patient? So let's go back to our original data again, and we'll go back to, let's go to this data. We still haven't finished our analysis of form and of function. We still haven't finished that analysis. And so let's get on to the last part of that analysis of composition, form, and function. And that's going inside this vessel and looking from the inside at the composition of this plaque and its form. And so what we see here is this piece of calcium that's at the origin of the diagonal vessel. And if you're going to go down this way, you'd go down the diagonal vessel. So let's go back here. This is, we're looking into the main stenosis, and we're looking into this complex plaque. This is a little diverticulum that's off this complex plaque. This is all fibrosis around here. You know, this is another little diverticulum up there. And so there's going to be some calcium in this wall that we're going to see. And if we come into here, we're seeing this is very complicated in here. And so more fibrosis, more fibrin come across here. So it's going to be a tough plaque. When you get in there and you want to dilate it, it's not going to be compressible lipid material. And so it's going to be fibrosis. This is the plaque continuing, and we're actually in the stenosis now, hanging in the stenosis, and we've just magnified it. You can see the shape is different inside here, and we've magnified the stenosis, and we're going to go out the other side of the stenosis. And here we go. We're going out the other side now, and now we're out of the stenosis, and we've got a branching here. So if we want to go back to the stenosis, you have to actually turn around. So now if we turn around, now we're looking back into the stenosis again, and we're seeing this kind of ovoid, or actually it's like a D. It's like the letter D here. And so we're going back. This is the shape of the mitral annulus. We're going back, looking backwards, going back through the plaque. We're actually into the complexity of the plaque now, piece of calcium in the wall, and we're moving back out of the plaque, back out of the plaque on the other side, and then we're going to be at the origin of the diagonal, where the diagonal comes off as well. And so we have to rotate around. Over here is the origin of the diagonal and the piece of calcium with the diagonal. And so, and there's looking back, there's the diagonal origin. It's going down this way. If we want to go down the diagonal, we have to change our course and move into this diagonal vessel. And here we go. We're moving into the diagonal now, and we're at the origin of the diagonal. So now we want to know the relationship of that diagonal to that plaque, because we want to make sure that we don't compromise the origin of this vessel. So we're going to say, well, let's put a wire down the diagonal during the angioplasty, and let's put the wire down the LAD more distally, and we'll separate that off. This is the piece of calcium where the diagonal originates. And so now we're back to the plaque, and we're looking down the plaque, and we're starting to move through the plaque again. Very complex ulcer, a lot of fibrosis and narrowing, and here's our D again. And now we're going through there on our way back. This is still some contrast that's left in there. We try to subtract out. There's a little branch coming off. So now we're moving distally down the LAD, and there we go, down the LAD, down the normal vessel. Still a little contrast left in there. And so another branch coming off down there. So now we understand more thoroughly in a micro section of what the complexity of this plaque is. And this is a 48-year-old guy. Actually, this looks like a monster here. Here's his eyes. There's a monster there. So, and his eyeballs there. So anyway, we've got that. We're looking at a very complex lesion, and we're looking at a very complex, but simple angioplasty. It should be, you know, dropping a wire in the diagonal and solving this problem. And so then we got to talk about what kind of stent do we put in there. Do you want a bioabsorbable stent? No, because it's on hold in Europe right now. It has to be part of a registry. They put it on hold because of thrombosis, early and late. So we sure don't want that. How about the new polymer Boston Scientific Synergy stent? Well, that's what I would take. I would tattoo that on my chest, because that's actually the best stent known to man today with zero thrombosis. And so that's pretty incredible. Zero thrombosis. So we're going to examine that. Now we understand the form composition, and we talked about risk. We talked about a mild myocardium subtended. So now we're going to talk about, we talked about what we're going to fix it with, and then who and when. And my when is tomorrow, which is actually, I saw him on the 17th and he got it on the 18th. So let's move through this. The complexity of the plaque, very important to understand. Complexity of this plaque, the double ulceration, a lipid lake, the convergent divergent double cone, the amount of fibrosis, the relationship to the proximal diagonal vessel. And so what happens to this? Why is this guy so at risk of sudden death? What can happen to him that's going to get him in trouble? And so platelet activation of triathlon competition in ultra-endurance trained athletes, the impact thrombin plasmin generation, catecholamine release. And so that turns out to be a fact that's well recognized and well known, that runners are susceptible to atherothrombosis. And so he's a perfect setup for that. Platelet activation from running, and then the presence of a double ulcer in the plaque. So he's not going to rupture his plaque. He's not going to rupture his plaque with a platelet lake and with a thin cap. He's going to actually thrombose in a deep crypt of one of those ulcers. And so you can see here's his stenosis on cardiac cath, and here's after he got angioplasty and stenting in cardiac cath. And then here's where we talked about the Synergy stent and how this stent is a bioabsorbable polymer coating that doesn't give long-term polymer exposure. And this is the most progressive stent that we have, and that's the one I want for this guy. And you can see 0% stent thrombosis rate. Wow, 0%. And all the stents that have been used and all the places this has been used, and we got 0 stent thrombosis. We can look at the blind spots in clinical cardiology and how common is back pain, acute coronary syndrome. And it's not very common, but it is a finding. And so you have to be aware which these patients are going to develop back pain at times, and it's going to be missed. They're going to have shoulder pain. They're going to get MRIs of their shoulder. They're going to get MRIs of their back. They're going to get acupuncture, chiropractic treatment for their coronary artery disease. And so everyone emphasizes back. I can't tell you I see much back pain from coronary artery disease, but you got to consider it as an option. Each presentation that we have here, we're going to have a Care Assure Nurse Navigator patient that we're going to show. And this is our patient for this week, who's going to be navigated at Memorial by Shannon. And so she came over and greeted this patient yesterday. And I want to show you what kind of risk we talk about on patients that are having hip surgery. And it's our demographics of our cardiac patients. And so here's a 74-year-old Caucasian married male for hip redo replacement, 428-17, right down the road. He's going to get this. He had an MI, angioplasty, but no stents in 1990. 2007, a hole in his heart, paroxysmal atrial fibrillation. I presume that's a patent foraminal valley. He had many CVAs, renal infarct, was anticoagulated, angioplasty and stents, 3-4-15, 4-23-16, 5-28-16, so not long ago. Complete heart block, treated with BiV pacer, ICD, subclavian vein blockage, secondary to the pacer wire, recurrent VT, treated with sotalol. That's because there's some myocardial mass that gives a macro reentry circuit, which is anterior apical hypokinesis, and you can see ejection fractions 23, 32, 37, hypertension, Parkinson's disease, GERD, COPD from smoking, back surgery, right lower lobe ground glass lesion being followed, pacer interrogation, no VT, no PAF, last VT April of 2016. So not much wrong with this guy, and he's going to have his hip, piece of cake, right? These are his medications: Entresto, Carbolevo, Coreg, Fluticasone, Prilosec, Pulmicort, Ranitidine, Simvastatin, Loratadine, aspirin, sotalol, and vitamins. You miss the sotalol, you go into atrial fibrillation. So got to make sure he gets his drugs. And so what's the complication of hip replacement in people in this age group? Well, we're talking about mortality of 6.9% or complications and mortality basically in certain individuals, 6.9% morbidity and mortality. Pulmonary embolus used to be the big thing, and now it's not true anymore because everybody's getting anticoagulated. So it's cardiovascular causes, myocardial infarction, heart failure, and cerebral vascular causes. So under 70 years of age, piece of cake. 70 to 79, no, more problems. 80, greater problems. 30-day, 90-day mortality for hip and for knee replacement. And there's no difference between hip or knee. No difference in terms of the statistics. And so we've got problems. We need to have a multidisciplinary approach to reduce mortality following the joint operation. And postoperative pain management is more difficult. Patients on opioids, man, it's hard to get people off of opioids. People on opioids have respiratory suppression post-op. They get aspiration. They're not easily dealt with. Their pain is not easily dealt with. And if we've got a lot of people on opiates who've had pain for a long time, we've got a big problem. And so this is the heart of the problem of the patient we have in the hospital right now that we've been navigating. And then we got a problem with the bundled episode. And so you have to remember these patients are being bundled now, so it's a discount to Medicare, and they're all referred and bundled to someone who's taking some risk. And so they don't want the risky patients, but the costs don't count until 72 hours before surgery. So we can do anything we want in terms of these bundled patients in the interval period before we get to that 72 hours in trying to refine their therapy and refine their risk or define their risk. And so here's a guy who's 77 who had hip replacement 8 years ago, and he was going to have hip replacement again, and he's had some angioplasty and atherectomy. He's got an anterior wall hypokinesis. Sounds very similar to this gentleman we're talking about. Ejection fraction is about the same. It's 37% on this guy, 40% on this one, and so it sounds like a similar patient. Saphenous vein ablation in the past. The other guy had some problem with one of the veins, upper extremities, and we got obstructive sleep apnea, diabetes, hypertension. What's the surgical risk? So not a lot different from this guy. So let's see what happened to this guy. Okay, well look, his left hip replaced. He went into atrial flutter. They called cardiology. 3 cardiology groups got in a fight as who's going to see the patient. The patient was very concerned about this argument going on out in the hall. 9 days post-op, because of anticoagulation, the wound bled and dehisced. He had readmission. He had an IND. He's on an antibiotic. He was on infection. He got DVT in the left lower extremity. He's put back on Coumadin. Coumadin continued for 6 months. Doxycycline indefinitely. Rehab delayed. Big time cost in this gentleman. So comparing these 2 patients, they are comparable and they have comparable risk. And so it'll be important for me to make sure, well, he's had atrial fibrillation too. Look, you know, so this guy's going to get atrial fibrillation. Well, he's on Sotalol. Hopefully that'll protect him. We ought to make sure he's not breaking through with atrial fibrillation. That'll be very important to know. And so, because that appears to have been, in this gentleman, that was the fatal flaw that caused this chain reaction that got him in trouble. So here's another patient that we had who had paroxysmal atrial fibrillation. We're seeing something in common here. And who also had something very similar to our runner. He had an ulcerated plaque. And so, well, that's no big deal. Let's see the ulcer. Here it is. There's an ulcer in this plaque. Just like you saw the 2 ulcers in the other plaque, here's an ulcer in this plaque. And so it's not a lipid pool that's the problem, it's the ulcer that's the problem in this guy. But that's no big deal for somebody getting hip surgery, is it? Well, wait a minute. You can look in the right atrium with a TEE and see during hip replacement there's fat, bone, cement, fibrin, all this material is in there activating platelets, and the platelet activation is evidenced by the beta thromboglobulin increase from alpha granulars during platelet activation, and it increases 200%, and the inflammatory reaction that's taking place. So we're talking ulcerated plaque plus platelet reactivity plus paroxysmal atrial fibrillation perhaps increases a chance of acute coronary insufficiency. And so that's a lethal combination. And so query, what does a marathon runner and a patient with hip surgery have in common? Sounds like what does a giraffe and an elephant have in common? Not much, but look, platelet activation is a cause of acute coronary insufficiency when ulcerated plaques are present, occurs in both patients. So we're not talking rupture of a thin fibrous cap and a liquid lake. We're talking an ulcerated plaque that's just sitting there. Doesn't look very risky, but you get some activated platelets, and voila, you've got an occlusion and a thrombosis. So thank you very much for your attendance today. We will post this on our website, which is privatecores.com, and I hope that you learned something. Bye-bye.